You're listening to Medscape's In Discussion series on myelofibrosis, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Tania Jain. Dr. Jain is an associate professor of oncology at the Johns Hopkins University School of Medicine, where myeloproliferative neoplasms are the focus of her research. And she's also the director of the Adult CAR T Cell Therapy Program for Hematological Malignancies at the Sidney Kimmel Comprehensive Cancer Center. Relevant disclosures can be found with the episode show notes on medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for use healthcare professionals.
Hello, everyone. I'm Tania Jain, and I'm back with our special guest, Dr. Prithviraj Bose, for our Myelofibrosis for Medscape in Discussion podcast. This is Season 2, Episode 4, and our topic today is going to be JAK inhibitors, an embarrassment of riches or a poverty of options. I'll quickly introduce Dr. Bose. Dr. Bose is a professor in the Department of Leukemia at University of Texas MD Anderson Cancer Center, and he has been very involved and is a very prolific clinical investigator in the field of myeloproliferative neoplasms, especially myelofibrosis. So we're excited to talk about this. This has been a topic that has been touched on numerous occasions, but I think certainly deserves a very focused discussion. So let me start by asking you what your approach with the 4 JAK inhibitors that are commercially available is.
Great question, obviously. I mean, we have 4 JAK inhibitors. Where, do they all fit? And what's sort of the, what are the considerations, right? When you pick one, how do you sequence, things like that. And I'm sure there are some differences in opinion as to where people use each drug. But I think all 4 are, very welcome to the field. I think something that is a bit sobering, I think, as you practice, as you see patients, is that, all 4 have a home. All 4 are actually needed, and sometimes you're surprised when a patient may not exactly check all the boxes that you would imagine from the literature, and you realize that that a particular JAK inhibitor is just not right for them, or another one is remarkably good for them. So I would say that I do keep in mind that ruxolitinib has a proven survival benefit. That is not to say that the others couldn't. It may well be a class effect, but I think there is something to be said for the fact that ruxolitinib is the only one that has demonstrated that. In the same breath, I should acknowledge that with fedratinib and pacritinib, they had full clinical holds. So it's never going to be possible for those, I think, to show a survival benefit. And then momelotinib was really compared mainly to ruxolitinib and to danazol, certainly was not compared to placebo. All the drugs have been studied in somewhat different populations, different lines of therapy. So there's a lot of caveats. But then again, ruxolitinib with its survival advantage, clearly a great drug for spleen and symptoms. I tend to start with that, in most patients. Now, I find fedratinib to be actually very useful in the second line in patients with a large spleen and good counts. Now, obviously, that's a bit hard to define. And we know that, it has data above 50 platelets and does not need dose adjustment and stuff. But again, when I have the sense that the counts are preserved, I'm not too worried about the counts tanking. The spleen is big, needs a potent drug. Fedratinib is my drug of choice in the second line. Now, with pacritinib and momelotinib, obviously both, are more tailored, let's say, for our cytopenic patients. They both hit ACVR1 or ALK2 and have the anemia benefit. To me, momelotinib has stronger data for anemia, which is reflected in its label. So generally, when anemia is my main priority in a given patient, I'm reaching for momelotinib. And at the same time, when the platelets are, really low in the sense that they are either below 50 or close to 50, I think I'm more comfortable with pacritinib because, one, again, it has the label for less than 50 and really in that space has the best data. But also, momelotinib can cause some thrombocytopenia. So I actually worry about that a little bit if the platelets are already in that, say, 50 to 75 range. So I'll choose usually pacritinib there. And also it helps that it has an anemia benefit, right? So because these patients don't come with just anemia or just thrombocytopenia, right? They usually coexist. So that can be helpful. But again, so anemia, my choice is usually momelotinib, severe thrombocytopenia, pacritinib, good counts, large spleen, second line, fedratinib, most frontline, ruxolitinib. I will say though that momelotinib has a place in frontline too. And I think that is yet to be fully defined. But I think the frontline space is right now probably shared by ruxolitinib for the most part, but also momelotinib because they have good data in the frontline setting, Simplify 1. And when you're starting with anemia, that is something you may want to consider. I think that's a bit of an unresolved question at this time.
I agree. I think I've always wondered in people with that borderline hemoglobin of like 8 to 10-ish, what is a better front line between momelotinib and ruxolitinib, especially because the spleen responses between the two, at least in one of the simplified studies, seem to be, non-inferior. So I like your approach. And I think very similar to what I end up following too with ruxolitinib as being sort of the default kind of option still. And in addition to all the things you said, I think the fact that we have the longevity of experience with it and can almost sort of predict whatever that word means in real life with it certainly adds to that level of comfort with ruxolitinib. I think 4 JAK inhibitors is a good strategy from a JAK inhibition, JAK-STAT pathway inhibition standpoint, and addressing that particular mechanism in this disease. Where do you think is room for progress now? If we were to look forward, where do you think we need to invest our investigations and efforts?
There's quite a few areas, right? So let me start with the anemia piece only because we were already talking about that sort of in this frontline ruxolitinib versus momelotinib context. I think I welcome the development of the anemia drugs. We have luspatercept in phase 3, fully accrued, awaiting those results. We have DISC-0974, the anti-hemojuvelin, very exciting, as well as elritercept, right? So another activin receptor ligand trap, also looking very exciting. So I think there is a place for these agents, even though we don't generally think of them as disease modifying or addressing the disease as a whole. These are all anemia drugs, right? At the end of the day, for the most part, I know there's been some interest in elritercept potentially leading to spleen symptom and anemia responses, but we'll have to wait and see, what the data shakes out as on that. But I think the value of these agents is, and we were going back to this, ruxolitinib may be our most potent JAK inhibitor. So I think, there is a value to optimizing the dose, right, of ruxolitinib. We know, from the work of Serge Verstovsek and others, that the spleen response to ruxolitinib is dose dependent and correlates with survival, right? So if you can give the hemoglobin a boost with these other agents, these add-on or ancillary sort of supportive agents, maybe you can maximize the ruxolitinib and maximize the benefit of that drug, right? So I think there is a value to developing anemia agents, even though we have momelotinib. And to that point, the Odyssey trial is actually looking at momelotinib plus luspatercept. So clearly, even though momelotinib does a great job on its own for anemia, I mean, I think there is still an unmet need, and I think these anemia drugs are certainly very, very welcome. Then I guess I'll move to, perhaps what was the thrust of your question, which is all these other non-JAK MOAs that we are studying, either with JAK or alone. And eventually all of them are, I think, studied with JAK, right? Like they start alone and then when there's comfort with the dosing and safety, they move into add-on or even frontline. So I think I'm excited about BET inhibition as a class. I know with pelabresib, we perhaps had a little bit of a less than desired outcome when there was, a lot of expectation around NASH 2023 that we would probably have an approval. But as you and I know, there were a couple of issues that threw some wrenches into that, with the symptoms and then the little bit of an imbalance in the blast transformation. But again, I'm very curious to see what the long term follow up of that shows. I don't think the blast thing is is a real concern. I mean, mechanistically, why would that be? But there was of course, at the end of the day, there was an imbalance, and that's obviously something we want to be very careful about, right? So that long-term follow-up is very important. The Insight BET inhibitor is looking quite exciting. It's nicely shaping up. So certainly looking forward to that. And then selinexor, right? So selinexor really, after the navitoclax pelabresib sort of, the wave, which has kind of died down a little bit because of what we just said, selinexor is now, I think, our front runner, if you talk about phase 3 upfront combos, right? Certainly a very potent agent. It's shown what it can do as a monotherapy in the essential trial. And the part one of the current trial, Sentry, showed us some remarkable results with 79% spleen and 58% symptom response, which we really haven't seen with other combos, not even with pelabresib. Again, comparing obviously across trials and acknowledging that it was only 14 patients in part one of Sentry that's based on. But certainly another trial accruing and approaching its goal of, I think, around 350 or so patients. So we'll see what that brings. And then, of course, one has to mention naftamadlin, right? So unique trial design. We've never seen this before in the field, but certainly a very interesting one, right? Where you start with Rux alone, and then if the patient does not meet both spleen and symptoms, right? So if they are suboptimal for both spleen and symptoms, you add on naftamadlin or placebo. So it's going to take a while. That's going to be a big, long trial, 600 patients, I think, ultimately hoping to randomize 180. But that's been another interesting drug. John Mascarenhas, I think 2 EHAs ago, presented the add-on cohort of their phase 2, where we saw 32% spleen and 32% symptoms. So pretty decent, actually very good, I would say, in the add-on setting. I think numerically might even be the best in the add-on setting. And there's that consistency with 32 spleen and 32 symptoms, right? I think that one for sure. And then finally, imetelstat, not to be forgotten. I mean, that's already on the market for MDS. It's been a little bit quiet for a couple of years in MF as the Impact MF trial continues to accrue and closes in on its goal of, I think, 320. So that one in the second line setting versus BAT, a bit hard to accrue here in the US, right? Because of the lack of JAK inhibition on the BAT arm. But certainly it will be an important drug. It has started out with this promise, if you will, of survival benefit. Certainly something to keep an eye on. And then finally, I think we would be remiss not to mention the new wave, right, of targeting driver mutations better, right? As I think is probably kind of sums it up, right? So these are, our JAK2 mutant selective, the type 2 from Ajax, which is based on very cool science from Ross Levine's lab, the immunotherapy approaches against CALR, whether that's bispecific or a straight up antibody. So all of those, I mean, if they really can hit the driver harder, then, as a colleague mentioned recently, you may not need other synergistic strategies. Maybe if you go after the driver and maybe do it a bit early in the disease, you could look at real disease modification. So again, some way away from reality, but I think those are, no less exciting than anything else.
That's totally true. I think your overall notion about a lot of excitement on the horizon is very well received, and there's a lot of optimism in terms of what options may be available in the future to target and how positioning these targeted agents will become as an add-on or a secondary therapy or a primary first line kind of therapy, especially if we start seeing molecular responses with these agents in a reliable manner. One might argue, are we heading towards more like a CML kind of approach where you truly can target the driver there? You brought up the imetelstat, and we don't talk often about it. So I'm going to probe you a little bit because this is one of the first studies, I think, in myelofibrosis where we're talking about an overall survival benefit. And I think the endpoints in clinical trials have come up in discussion time and again over the last couple of years with the naftamadlin frontline study and the pelabresib, both the manifest and the transform. to question what are the endpoints, and we touched on this a little bit on a prior episode as well. But I'd like to hear how your excitement stands about imetelstat, or just the overall thought about using survival or thinking about survival as an endpoint for a myelofibrosis study.
Well, I'm certainly intrigued by imetelstat. I mean, again, John published in JCO a couple of years ago now that you had a 28-month median survival with imetelstat at the 9.4 every 3 weeks dosing in the Embark study, right? And this was in the post-JAK setting. They did define JAK failure, so it was not just anyone who's been on prior JAK, right? So because one has to be careful when one looks at the studies, because some studies, for example, if you look at the original Freedom 2, there was really no definition of JAK failure. So it's important to define it, which was subsequently done, right? When Freedom 2 was reanalyzed. Oh, I'm so sorry. I meant Jakarta 2. When Jakarta 2 was reanalyzed and then the Freedom trials were designed, etc. Back to imetelstat. I mean, Embark was a trial that defined, rigorously JAK inhibitor failure and showed this apparent survival benefit because we assume that it's going to be 13 to 14 months. Several of us have published that. That's us, Moffitt, Dr. Palandre in Italy, that when you fail ruxolitinib, you're looking at about 14 months median. So obviously the 28 months was quite eye-opening. And now again, there are obviously the caveats of these all being very different studies. For example, something Dr. Palandri has nicely shown is that yes, it's 14 months, but it's mostly driven by those who develop blast phase, right? So if you stay in chronic phase after ruxolitinib failure, quote unquote, I don't know if that is 14 months. So I will throw that out. I mean, it's the totality, that is 14 months, but many of them, at least in the Palandri study, it was really driven by those who ended up in blast phase, which you and I know is extremely bad, right? So back to imetelstat, I think overall survival in the second line is very feasible. I think that is totally feasible. The issue is in frontline, right? In frontline, spleen and symptoms have been criticized. That is true, and perhaps they are better tailored to JAK inhibitors, and that's how they evolved, right? SVR35, TSS50, all evolved in the context of Rux and its successors. Maybe they don't apply as well to the novel agents, but the problem, as I see it, is that I don't know that we can really at this time yet, reliably say whether it's cytokines, whether it's VAF, whether it's bone marrow fibrosis, that we have a solid surrogate for survival. And that is why I feel that spleen and symptoms for the immediate future, as well as transfusion independence, very important. I think momelotinib, luspatercept have shown us that that's an important endpoint. I think these things still have more teeth today, despite all their shortcomings, than some of the putative markers of disease modification, where there's not much uniformity across trials. I mean, there's a lot of heterogeneity between cytokines measured or the thresholds of VAF reduction, which make it a bit difficult or murky to compare across trials. So I guess that's where I am on that.
I think that's a fair point. I'm actually excited that we're even, starting to talk about survival, right? I mean, it's taken a long time coming to get there. I think it's a positive move that we're starting to talk about it, think about it. It seems like, at least in theory, in concept, there may be drugs that can be considered for trials with an endpoint, or even a secondary or a primary endpoint of survival, like the targeted agents or imetelstat, and maybe in combination with JAK inhibitors and so forth. As a transplanter, I try to practice both transplant and non-transplant therapies, so I'm not biased about clinical trials, right? I mean, I still get to do both and enjoy the MPN field as a whole. Let me pick your brain a little bit on PP53. Never exciting to see that, always a little worrisome to see that. And for some reason, I feel I've seen more of these in the last 6 to 12 months than maybe in the years prior. And I'm not, that could just be a matter of chance. But what is your approach there? Because I feel like outside of maybe managing spleen and symptoms with drugs, which also I don't think do a good job truly in truly symptomatic TP53s who are coming in with a lot of pains and fevers, what is your usual approach and what has worked for you, if anything?
The spotlight is very much on that, or certainly, we have seen more attention on TP53 in MPNs recently. There were two oral presentations at ASH in the same session on multi-hit, right? And what that means in MPNs. But you're right. I mean, today we're not at a point where therapy is any different uh, at all based on TP53, right? And obviously, some therapies like the MDM2 will not work if TP53 is mutated. So no, I mean, unfortunately, I don't think, in the AML field, I believe they have some leads on certain therapies that could be, TP53 agnostic, and perhaps again, nothing has panned out yet in a major way, but at least there is some thought that certain drugs may be preferable in TP53, certain investigational drugs, of course. But for us, I don't think we are there. I don't think therapy is affected in any way today. Now, of course, cellular therapy is generally agnostic of that, right? So if you talk about, the emerging cellular therapies, which are primarily against mutant CALR, and you have been involved in some of the cutting edge work with CAR T cells, maybe those, right, could solve this issue to some degree. But otherwise, I'm not sure that anything right now addresses that problem.
Yeah, I mean, if we were to sort of extrapolate from our B cell malignancy world, there's been what I would say a better success with cellular therapy in T53, but doesn't seem to be a home run even with that, unfortunately, at least as of yet. But similarly with transplant, right? I mean, there is certainly a higher risk of relapse in T53 disease compared to non T53 or some of the other non T53 high risk mutations. I think time will tell where cellular therapy strategies or targeted CALR or JAK2 targeted strategies will stand, and how, if there are subclones, if the TP53 is a subclone or a separate clone altogether, how these behave in response to these targeted agents if they were to come to the mainstream and we had the ability to learn about them more. Share with me some thoughts on interferons. There's been a lot of excitement around it. There have been approvals in early MPNs, and I heard one of my colleagues make this joke, obviously in a bit of a hyperbolic sense, but in that she's using it like water recently. Tell me how interferon is being used in your clinic.
A lot more than before, no question. And you're exactly right. It's gained a lot of momentum, right? I mean, some of it is the approval of ROPEG in the US in the fall of 2021. Obviously, Pegasus was around for a long time, but then to actually have an approved interferon made a difference. So we have that. We have top line results on ROPEG in ET this year, which are positive, and we look forward to. I believe it's an oral presentation at ASCO on the Surpass ET trial. Maybe later in the year, we might hear about the Exceed ET trial. So one can probably reasonably hope that it will get approved for ET. Obviously, a regulatory approval just makes it easier, right, to obtain it and everything. It makes a difference on the ground in terms of being able to use it. And I think, if you look at all the data, right, a couple of things I'll point out. One is the event free survival improvement that was seen in the PROUD and continuation PV studies. So that's one. And of course, in addition to the well known effect of interferons on lowering the JAK2 VAF, right? So, and PV is the best place to show that because it's all JAK2 driven. That is done nicely by ROPEG. I think 20% rate of complete molecular response, if I remember right, from the PROUD and Conti PV, and that event free survival difference. And then Dr. Silver has shown, of course, in their Cornell experience, historical experience, that there appears to be an improvement in myelofibrosis free survival and overall survival with Pegasus, right? So I think these things, all these data sets coming out are really fueling the enthusiasm that this could be truly disease modifying. And I think this event-free survival is exciting because, an event is either a clot or MF or AML or death, obviously. And if you can reduce that, it's a reasonable composite endpoint. Also, should throw in there that with RUX, we've now seen that with RUX in the MAGIC PV study in the second line. We may be on the cusp of disease modification in PV, like maybe even closer than in MF. For all the work in MF, I think the success is more in PV, which actually makes sense because it's a less complicated disease. It's one gene for the most part, less genomically complicated, earlier MPN, as you said.
Yeah, I agree. I think my approach, for what it's worth, is interferons, the earlier the better, because the longer time that you can give a patient with interferons to work on that disease modification, because as we know, they take time, right? I mean, this is years worth of therapy, and that's what we try to tell our patients when we're presenting it to them, that this is not something to expect benefit from in 2 months or 3 months. This is years. Again, similar to like what we saw with CML, for example, although, the strategy is slightly different, but certainly a long-term treatment. So the earlier you can introduce, the hope is that the a better chance of some advantage there. We loved talking about all of this, Dr. Bose, hearing your approach and your sort of algorithm on JAK inhibitors, which I very much appreciate. I think you pointed out some of the key areas that we as a field need to continue to work on and hopefully move the field forward with all of the exciting products in the pipeline, the newer mechanisms of action, the targeted agents, hopefully engaging and activating some T cells to do some work beyond transplant. I think a lot of excitement to think about. And I wonder if we were to do this podcast 10 years from now, we'll be having a totally different discussion.
Of course, I'm sure.
All right, wonderful. I hope everybody enjoyed. I very much so did. Thank you again, Dr. Bose, and we'll sign off for this episode. Thank you, everyone.
Thanks for listening to Medscape's In Discussion Myelofibrosis podcast series with our host, Dr. Tania Jain. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out medscape.com or the Medscape app for show notes, links, and more information on myelofibrosis.